I am speaking to you all today about a topic that's near and dear to my heart and very clinically relevant for me, demystifying hospice and palliative care. So as Allison mentioned, I have quite a bit of experience in both palliative and geriatric care that I'll talk to you a bit about on the next slide. But in this presentation, I'm really hoping to debunk some of the myths about hospice and palliative care, answer some of your key questions, and hopefully give you just a little bit more information so you can make informed choices for yourselves and your loved ones. Um, as Allison mentioned, we are going to use the chat function because I'll ask you to participate in a couple of different moments. So the more you can participate, the better that will be on our end. Just if you're able to be prepared to use that chat function, and I will walk you through when and how to do that. And if you have questions as the presentation goes by, feel free to put those in the chat. I will certainly be making sure there's time at the end of this presentation for questions. I wanted to make sure the presentation itself is not going to take up the whole time. So I do want to make sure we have time to attend to your questions. All right. So I want to tell you, you got my bio, but I'm going to highlight a few aspects about myself and my clinical practice so you know kind of where I'm coming from, and also how I came to this work. So my first job as a nurse was working in critical care at Penn, where I cared for people who were very seriously ill, along with their families. And often these families found themselves in a life-threatening situation completely by surprise and were suddenly in this moment of crisis that they really never expected to be in. And I found that our palliative care team at Penn was really exceptionally good at supporting patients through those moments. And while I was working as a critical care nurse, not on the palliative care team at that time, I was really hooked into that palliative care philosophy. And then I'll tell you a little bit more about how I got more and more experience in that type of care. So after that, I worked at the Penn Frontotemporal Degeneration Center, which some of you might be familiar with, but is very similar to the Penn Memory Center, where we supported people who were diagnosed with typically an early onset dementia, along with their care partners and families. And here, what I saw and learned was this long journey of dementia that patients and families go through, and the caregiving that goes along with it. And I realized how much support people needed along the entire journey of their illness, and not just at these end or crisis moments. And next, I took a slight detour away from working with folks with dementia, where I worked actually at the Abramson Cancer Center here at Penn, because here is where I wanted to get some experience specifically in palliative care, which I'm going to talk you through definitions in a few moments. But palliative care has really existed in cancer care for quite some time. So most cancer centers have really robust palliative care programs. And I wanted to get some experience in that area and some specialized training in palliative care that I could then bring back to the dementia space. So at the Cancer Center at Penn, I coordinated a palliative care program that supported the needs of patients and families with cancer. And the lesson that I learned and will take with me through my entire career is how essential it is to have a team-based approach to caring for people with serious illnesses. I worked with an incredible team of social workers, nurses, chaplains, physical therapists, psychologists, who all were essential in providing this comprehensive holistic care to people, in this case with cancer, but we can definitely say it is true for people with all serious illnesses. And then currently, I'm working as a geriatric and palliative care nurse practitioner at NYU Langone, now back on the inpatient setting. So again, I'm seeing people in these moments of crisis where they're very ill and needing to make decisions about their care in the moment and also their expected care in the future. And this is reminding me, kind of taking me back to my original work as a critical care nurse, but now with all the experience of hospice and palliative care and dementia care, to be able to help better guide patients and families through those moments of crisis. And through all of these experiences, I've learned so much from my team and the patients and families we cared for about what people need to live the best lives they can until the very end, which is really a fundamental aspect of palliative and hospice care. And I feel incredibly privileged to do this work, supporting people in some of their most challenging moments. And I think if you ever have the opportunity to interact with palliative and hospice care providers, you will find that many people say that it's really kind of a special community of providers. Okay, I promised we would do some participation. So what I'm going to ask you to do is an exercise called a waterfall. And what I'll do is give you a prompt and ask you to type your answer into the chat, but don't press enter until I say so that when you press enter, we'll see all of the answers all at once. And they'll go just to myself and Allison. But so I'll give you a prompt and ask you to type in your answer and then tell you when to press enter. And I'll share the responses that are coming in. So I've given you the instructions on the slide. And the first question that I'd like you to answer, to type into the chat, but don't press enter yet, is what words come to mind when you think of palliative care? So I've given you a moment to answer, and now I'll ask you to press enter and send those responses over to us. Great. I'm seeing some responses in here. So we have kindness, relief, care, impending death, comfort, assist, gentle dying, end of life, death, no idea. So these are all excellent answers, and I think are very reflective of what most people's experience is with palliative care, that this is care that's focused on impending death or towards the end of somebody's life. I think it's also really common that folks have no idea what palliative care is, which is why we do exercises like this and informational sessions like this. All right, we're going to do one more. And this might be surprising that this is a different question. But again, I'll ask you to type your answer into the chat and not press enter until I tell you to. What words come to mind when you think of the word hospice? So type your answer into the chat. And now that I've given you a moment, I'll ask you to press enter so we can see those responses. Wonderful. So we've got acknowledging death, cancer, end of life, caring, peaceful death and support, cancer, tender care, little time death, or little time left, dying with dignity, end of life, comfort, easing of pain, death, cancer, and a place to die. So the word cancer has come up a lot, and you are all absolutely right that there's a strong association with cancer and hospice, and actually the hospice benefit as it's designed was designed to best meet the needs of people living with cancer. And I'll explain how and why that can be challenging for folks who are living with and at the end of their lives with dementia, and how we can navigate the system and make it work for that group. Um, Again, a focus on end of life and death and dying, with also this focus on a peaceful, symptom controlled death, that pain is being controlled. Um, and that is also a very correct view of what hospice care is. And it being a place to die, I think is sometimes true, but we'll talk about where hospice occurs, and it actually can occur in a lot of different places. That hospice is a type of care and not necessarily the place where it's provided, and we'll talk a little bit more about that later. So thank you for doing that exercise with me. This is a really helpful place for us to start from. So, palliative care, I'm going to give you the definition that that the field has developed over many years. It's actually, um, palliative care has existed in philosophy and theory for decades, but didn't become a medical specialty until the 90s. So it's fairly new, and why lots of folks don't quite know what it is. So, palliative care is specialized care for people living with serious, often life limiting illnesses. It's focused on providing patients with relief from symptoms. Often those are physical symptoms, but also the emotional and stressful symptoms of a serious illness, regardless of diagnosis. So, this is not something that only people with cancer have access to. It can be any serious illness diagnosis. And the goal of palliative care is to improve quality of life for both the patient and the family partners. And that's identified family. So that may not be somebody who's biologically related, but who is in that person's sphere. So it's important to know that this type of care includes a patient and their support system. Palliative care is provided by a team of specialists. So it's multidisciplinary, which means that you're not just getting a physician or a nurse, you're often getting more members of a team that provide different types of care. And they work with patients and other providers to provide this kind of extra layer of support alongside of the care that a patient is getting already. Palliative care is appropriate at any age and at any stage in a serious illness. And this is the key here, can be provided together with curative treatment. So, palliative care is not necessarily just for people who are at the end of life, who have said treatments that are directed towards my diagnosis are no longer appropriate. That's actually typical of hospice care, but palliative care, um, we could start at the time of diagnosis to support somebody in understanding their diagnosis, making plans for the future, and managing the symptoms that come alongside of it. I'm going to hopefully be able to navigate quickly and show you a video. Let's see, about palliative care.
Why would palliative care be?
Allison, can you just give me a thumbs up if you can hear this? Okay.
We can hear it. We're good.
All right, great. We're going to play this very short video about palliative care.
You write for a patient and his or her family. Let's start with some basics. What does palliative care mean? The term palliative care comes from the root word palliate, which means to alleviate, relieve, or soothe. Palliative care involves medical specialists who focus on quality of life to alleviate, relieve, or soothe the issues that are affecting how a person feels physically, emotionally, spiritually, and socially. If a person has a serious health condition or diagnosis, then palliative care is right for him or her. Palliative care is for all persons who consider their illness or health condition a serious one, whatever the diagnosis. It is not reserved for those with only specific conditions, a certain stage of disease or prognosis, or those near the end of life. This is a common misunderstanding. Palliative care is meant to help people live as long as possible, as well as possible. Sometimes, palliative care is provided at the same time that patients are receiving medical treatments to help them live longer, like dialysis, chemotherapy, or medications. Other times, the focus is on maximizing the supportive care options that make people feel better. Importantly, choosing palliative care does not necessarily mean stopping anything. It means focusing on what makes sense for patients and their loved ones, especially as they encounter changes along their journey. Quality of life issues can be complex. We know that most patients have a medical team, including primary care clinicians and specialists who have likely been focused on some of these issues all along. But sometimes these medical teams may feel adding an extra layer of support from palliative care experts would be of even more help. So, what does palliative care do? Well, palliative care can help with several aspects of serious illness care. Often, palliative care experts are asked to help when there are issues regarding how patients feel, such as pain, shortness of breath, tiredness, or low appetite. They also explore the issues that may lead to emotional or mental stress, and things that may make a person anxious or worried. Also, palliative care experts want to understand things that give a person hope and strength. Knowing these helps better understand the whole person and his or her motivations and priorities. Palliative care experts also assist with planning for the future to make sure wishes and preferences are respected whenever and wherever care is received. They also focus on planning and making decisions for the stressful twists and turns that often come along with the journey with a serious health condition. Further, palliative care experts can help with the difficulties faced by loved ones and caregivers to make sure they feel supported. Palliative care understands the important role these people play in making patients feel better. Most importantly, palliative care experts provide an extra layer of support to partner with other care providers and make sure all the bases are covered. Let's quickly summarize. Palliative care may be useful for any patient with a serious health condition, no matter what the condition or prognosis. Patients may benefit from a palliative care expert at any time, from the moment of diagnosis of a serious condition or any time after. Being seen by a palliative care expert does not mean things are going badly. Rather, it means that a patient's medical team wants him or her to get the best and most complete care possible.
Wonderful. Thank you all for indulging with me in that. I think that video does a really excellent job of summarizing palliative care and really hits on some of excuse me, some of the points that I really wanted to stress here, which is that palliative care is available for anyone at any age and stage of illness, is provided by a multidisciplinary team, is focused on symptom and stress management and relieving the suffering that can occur with serious illness, and can be provided alongside with curative treatment. So I hope that clarifies a few things, but we are going to go into more details. So I wanted to show you this diagram that depicts the trajectory of an illness at the bottom over time, and shows the balance between restorative or illness-directed care in green. And that is care, like, for example, for cancer might be chemotherapy, surgeries. For dementia would be things like Aricept or Namenda, or new therapies that are being developed. And palliative care, which is in yellow at the bottom, is the care that focuses on comfort and quality of life. And what you'll see that this graph is showing you is that initially there's a strong focus on treatment-directed care that can gradually taper off over time and focus more on the palliative aspects of care. The line between the two is graded and wavy because there's often a fluid back and forth between the two, especially when they're working together very well in conjunction. And there's kind of a collaboration between restorative care providers, like in dementia, that's often a neurologist or perhaps a primary care provider, and a palliative care provider like myself. And also, there's often moments in the illness where one takes precedent over the other. And toward the end, if a person chooses hospice, palliative care, or in the palliative care philosophy, will become the main focus of care. And you'll also note, so this dotted line here is a person's death, and there's actually care that's provided after a person's death through the hospice care benefit called bereavement care that lasts for 6 to 12 months after diagnosis to support families and loved ones through that bereavement process. So this gives you an idea of what restorative care and palliative care could look like through the course of somebody's illness. So who is it for? Palliative care is for people with what we often call a serious illness, which is a health condition that carries a high risk of mortality. So there are sometimes life limiting, which means that that the diagnosis is likely to lead to the person's death, um, or or these diagnoses negatively impact a person's daily function, quality of life, or excessively strain a caregiver. While often it's for people with a serious life-limiting illness, we also are seeing more palliative care being provided to people who have a diagnosis that might be curable. This is often the case with a significant cancer that treatment causes a lot of symptoms, impacts function, impacts caregivers, and they have a lot of high symptom needs. That person is still appropriate for palliative care. So again, you'll note that palliative care is for any diagnosis, includes caregivers, focuses on function, and goes beyond the final days. So I've said a lot about palliative care, but I think what's really valuable is understanding, what does it actually look like? And so for those of you who have heard of palliative care or seen it in action, I want you to think about what that looked like, where it was taking place, and who was on the team. We often joke that once you've seen one palliative care team, you've seen one palliative care team, because they tend to look different depending on the environment that you're in, the resources that are available, the needs of the patients and families. So I'll walk you through what tends to be the different models of palliative care. In terms of who is on the team or team composition, palliative care is by nature inherently multidisciplinary, which means that there are multiple providers on the team. It's typically not, as I've said before, provided by one physician or one nurse. But again, who exactly is on the team depends on the needs of the population and the available resources. Next, we think about the patient population that is served by palliative care. This can be different depending on the need and availability of resources again, and therefore often teams are tailored to the specific needs of the patient population. Like our palliative care team at the Cancer Center had a cancer genetics therapist, a cancer specific social worker, and nutritionist, because often there were needs related to nausea or difficulty swallowing and eating. So our team specifically met the needs of patients and families who were part of the program. And then where can you get palliative care? So palliative care can be in any location that people receive healthcare, but many are in the hospital setting and often in large academic medical centers like Penn. Although we're really seeing a big shift in this over the past 5 years toward there being more options for people in the outpatient or community-based setting, in nursing homes, and in the home-based setting. So that's really where I see this field growing and there being a big need. Sorry. And my last point is this is a little bit in the weeds of palliative care, but there's a difference between something called primary palliative care and specialty palliative care. Primary palliative care includes the skills that all healthcare workers have, because I bet a number of you are thinking, as I'm describing palliative care, why isn't this just all healthcare? And for the most part, it should be. All healthcare should be focused on managing symptoms and making people feel as well as possible for as long as possible. And those skills we call primary palliative care, and all healthcare providers should have some skills in those areas. But then there's specialty palliative care, folks like myself and my coworkers who have extra training in palliative care to meet people's needs that go above and beyond what anybody in the healthcare system could manage. And that is, I'm talking more about specialty palliative care in this presentation. Okay, so digging in a little bit into what a team could look like. So I wanted to give you the range of options of the type of providers that could be on a palliative care team. It's a lot. It could be occupational therapy, physical therapy, speech and language pathology, nursing aides, administration, chaplains, social work, psychology, complementary and alternative therapies, nurse practitioners, or physician's assistants, physicians and nurses. But typically what we see in most palliative care teams is they have at least a nurse, physician, or advanced practice provider, like a nurse practitioner or physician's assistant, and a social worker or a chaplain. I would say our gold standard is a nurse, physician, or advanced practice provider, one of those, with a social worker and a chaplain. So that's what typically most inpatient palliative care teams have. And what I would look for in terms of a quality palliative care team. As I mentioned, palliative care programs are becoming more and more prevalent in hospital systems. So our first issue in palliative care was getting them in the hospital even. So in 2000, you can see that there were around 20% of hospitals who had a palliative care program. And in 2015, when this slide was put together, almost 80% of hospitals had a palliative care program. So this has grown hugely in the last 15 years. And our next foray and the next frontier is making sure these resources also move to the community setting where people are receiving most of their care. So how can you find care? There are many resources to access palliative care, including the websites that I've included here. And this picture on the left shows you, I just did a search, all of the palliative care programs within 100 miles of Philadelphia. And these resources can be incredibly valuable for you to advocate for yourself and your loved ones. But I think one of the best ways to access palliative care is to work with your current providers for whatever serious illness you're interested in receiving palliative care for, and say, you know, I've heard about palliative care. I think it might be right for me and my loved one. Can you help connect me with resources, or can you tell me about the resources that you've worked with? And that may help you and your loved one find resources that are a little bit more tailored to the needs. So a neurologist might know of some dementia-specific palliative care programs, or they may already work with one. And some programs even have a palliative care specialist who's embedded within memory care clinics. So I've talked a lot about palliative care, but I want to talk about the difference between hospice and palliative care. I think hospice is often more commonly recognized among folks. So I want you to think about palliative care as an umbrella term for anyone who has serious illness, and hospice care as a special kind of care that's specifically for people who are in the last 6 months or less of their lives. So again, palliative care is the big umbrella. Hospice care is specialized care for people who are at the last 6 months or less of life. And then I'll highlight a few key differences. So in terms of treatments that you can access, most hospices don't allow for disease-directed treatments. Again, that's things like chemotherapy, dialysis. For dementia, it could be continuing Aricept or Namenda. So while you're on the hospice service, those are typically discontinued during hospice care. Whereas with palliative care, you can continue those treatments. It doesn't impact things. Next, eligibility. So who's eligible? Palliative care is for anyone with a serious illness at any stage of the illness. It could be at diagnosis. It could be where they have years to live, months to live, or weeks to live. Whereas hospice is specifically for people who are in the last 6 months or less of life. And then finally, I think it's important to think about the payment structure because it influences the type of care that's happening. So palliative care is a specialist healthcare service, just like seeing a neurologist or an oncologist, and that would be on the outpatient side. So you might have a specialist copay if you're seeing a palliative care provider on the outpatient setting. In the hospital setting, it's lumped in with care. So it's paid for in the entire hospital stay. While hospice is its own service covered by the Medicare hospice benefit. So many people will transition from the type of coverage that they have to the Medicare hospice benefit that covers the hospice type care on a per day rate. So essentially the hospice team gets X amount of money to provide wraparound hospice care services, and they are providing all of the services, which is why they typically don't include things like treatment directed care like dialysis or chemotherapy. Most commercial insurances, Medicare definitely covers hospice, but most commercial insurances these days have a Medicare benefit. But that's something, or have a hospice benefit. But that's something that you might want to ask a provider if you're switching over to hospice. So the hospice model originated in England with a woman we call kind of the mother of hospice and palliative care, Dame Cecily Saunders, and preceded the palliative care specialty. So hospice existed as a medical specialty before palliative care did, although they share the same philosophy. So again, just pointing out a few of the key differences. Hospice is for patients with a life expectancy of less than 6 months. There was a very specific Medicare benefit passed by Congress where 2 independent providers need to agree that a patient is likely to meet the life expectancy criteria. So we say like an 80 to 90% chance that they're likely to die within 6 months. That does not mean that if a patient doesn't die within 6 months, they stop receiving the benefit. What we do is we go out and see patients different. In the beginning, I think it's every 30 days and eventually every 90 days where you have to recertify somebody. So at that point, you would say, all right, now at this point where we are, does the person still meet criteria for being likely 6 months or less to live? So even if that target is moving a little bit, a patient could technically receive hospice care for longer than 6 months. That being said, if they no longer meet eligibility criteria, if they have a sudden improvement in care, then they might transition off of hospice back to traditional care, which is okay, but can be challenging in terms of transitioning care teams. The other thing that we haven't talked about yet is the location of care. So hospice is most often provided at home, which means that care providers come out to the home, usually nurses, an aide, typically there's a social worker included. Um, but it's not 24/7 care. So it still requires a fair amount of care and support from a caregiver who's like typically an unpaid caregiver. So I want to make sure that this is clear to folks because I've often heard people say, "Oh, hospice is a place that you go to and you get all of the care provided for," but that's not always the case. Hospice care provided at home does require support from an unpaid, often family caregiver. There is hospice in facilities, so often nursing homes have hospice services that they can provide. And then there are also hospice facilities like a hospice home. There are a few here in Philadelphia that we partner with. And those are for people who cannot safely be taken care of in the home setting. Um, and then there's inpatient hospice, which is done in a hospital setting. And that's typically for people who have hospice symptom needs that are around the clock. So somebody who might need pain management via a drip, an IV infusion, or somebody who maybe is having seizures. But I would say that's the minority of patients are seen in that inpatient hospice setting. I wrote down the types of care, the names that we call that. So hospice care at home is called routine home care. There's also an option called continuous home care that we can use if somebody needs a short-term amount of increased support. So let's say they're having a lot of pain and I would like to send out a nurse to see that person more frequently. This typically happens right at hospice admission, the beginning of hospice, or at the end when somebody is actively dying. And we have the option in hospice to increase those services and provide more intensive care in the home setting. If we can't meet the needs through either of those types of hospice, then we have general inpatient hospice, which is either in a hospital or a residential setting. And then there's something called inpatient respite care. So everybody who is on hospice has the option for up to 7 days of respite care to provide some relief from caregiving duties. So it's helpful to know who gets hospice care. So this is not evenly distributed. So we know that there are some people who are more likely to receive hospice care than others. It's fairly even in terms of gender, but often more women receive hospice. In terms of age, it's associated with older age, but like we said, it is not a requirement. So you don't have to be on Medicare to receive hospice. It's more about the diagnosis that is uh, is making you eligible for hospice. In terms of race, this shows the percentage of people within each race receiving hospice care. But 86.5% of the entire population of people receiving hospice care in the US is white. So we're seeing a lot of disparities that not a lot of folks of color are receiving access to this type of care. And that's for a number of reasons, but something that hospice and palliative care is really focused on understanding and trying to help change some of the disparities there, making sure that everybody who does want this type of care is able to access it. And as we talked about before, cancer is the most common diagnosis that we see in hospice care, though we also know that it's beneficial for people with cardiac illnesses, dementia, respiratory illnesses like COPD and stroke. So, how much care is received? Although the length of service is getting longer, so the median length of days that people receive hospice care, I think this is really important, is 24 days. Yet I've said to you already that what designates somebody as eligible for hospice is having 6 months or less to live. So somebody is potentially eligible for 6 months of hospice care, but most people who are receiving hospice care receive it for a very short number of days and typically very much at the end of their lives. This is important because I think that people could very likely start hospice sooner than they do. And it's a hard decision to make, and it's really personalized. And we'll talk about when and how to make that choice. But just know that this service is available for much longer than most people get it. So we see this large percentage of people, almost 30% of people only get it for 1 to 7 days. And it's a very wonderful, comprehensive set of services that can provide really excellent relief and care in the last months to weeks of somebody's life. So when is the right time? So I alluded to the fact that we would talk about how do you know when it's the right time for hospice? And I'm going to talk to you a little bit about the different trajectories that we see at end of life as a way to get into this topic. So this has time at the bottom and function on the y-axis here, the up and down one. So this is a trajectory at the end of life that's commonly seen in people with cancer, where they're very functional for a period of time, and then they have a sharp decline in function towards their death. And we have a pretty good idea that people are headed toward the end of their lives, and that time is fairly compact. This is what the hospice model was designed for. However, only about 5% of people die this way. So we can see why it can be challenging to determine that time at which somebody's making this like clear downward turn and when hospice is appropriate. So let's look at some of the other trajectories that people tend to take. So this trajectory is typical in what we often see in heart failure or COPD, which is a lung disease, or kidney disease or liver failure, where somebody has dips in function, typically like a healthcare crisis. It might be a hospitalization or a worsening in health that then dips them generally below where they were functioning before. And they have this sort of slow, steady stepwards decline over time and move toward their death. So it can be really hard to determine which of these dips is the one that tends to move somebody closer to the end of their life. I like to think of each of these crises as an option, as a moment to say, where are we right now? Where do we expect to be going? And what are the person's goals? And is a rehab model where we're trying to regain functioning the right choice? Or is a hospice approach where we're focusing on quality of care and comfort the right approach? So each of these moments, I think, is an opportunity to ask the question of, are we still on the right track? And is this really still meeting our needs? This is most commonly the type of death that people, at least in their older age, have. This happens in about 80% of older adults. And then I wanted to show you the frailty trajectory, which is actually a very common for people who have dementia and Alzheimer's disease, where it's a very slow but progressive functional decline. Sometimes you have these moments of health crisis that look more similar to organ failure like this, but often it's this very slow, long, protracted period of time. This makes it really hard for even healthcare providers to say when somebody likely has 6 months or less to live. Um, and death at the end of this trajectory is typically the result of some other organ function being impacted, like a really bad infection or kidney failure. And it often takes the family by surprise because the patient has been maybe fading or changing for a long time, but not actively dying. So I think this can be a really challenging trajectory to think about when hospice is the right time, but I'm going to give you some tips. The last trajectory of end of life is a sudden death. This is in the case of like a heart attack or an accident. Often I hear people say this is the type of death that I would want. I'm functioning, and then I die. It happens only in about 10% of deaths. So this is a very uncommon type of death. And for this type of death, hospice is typically not the right moment of care because you have no warning that this is happening. So here is where I'm going to dig into some of the details of how we determine somebody is eligible for hospice with dementia, because I hope that it will give you some insight into when it is the right time. So there are strict criteria that we as clinicians use to determine if somebody's eligible. The first one is this thing called the FAST score. The FAST score is a measure of how well somebody is functioning. And to be eligible for hospice, the first criteria a person with dementia must meet is that they must be at least a FAST 7 score, which I'll tell you is a pretty advanced level of dementia. So somebody with a FAST 7 score, the lowest level there is the ability to speak is limited to 6 or fewer words. That can be different if somebody's dementia is specifically impacting their speech. And we can talk about that, but their function is typically very low. They've already gone through typically the stages of FAST stage 6, which is having difficulty with almost all of their basic activities of daily living, things like their ability to put on clothes, bathing, using the toilet. They may have urinary incontinence or fecal incontinence. And then the more severe stages of FAST 7 are that speech continues to decline. The person is no longer able to walk without assistance. They cannot sit up without assistance. They cannot smile, or they cannot hold up their head independently. So typically somebody's function is very, very impacted for them to be eligible for hospice with dementia. And then, so that's the first thing they need to meet. And then the second criteria that they need to meet is either to have a disease-related complication or another significant health problem that's been going on for more than a year or more. So some of the disease-related complications that could occur is that if somebody has pneumonia, typically an aspiration-related pneumonia, a bladder infection or UTI, a blood infection that we would call that sepsis, recurrent fevers, difficulty eating, poor nutrition, a pressure sore or pressure ulcer, a hip fracture, delirium, which is an acute change in mental status that's typically fluctuating and can accompany hospitalizations or often infection, and then or recurrent hospitalization. So we have to see this sort of pattern that there have been a number of complications related to somebody's dementia. Or they could also have another serious health condition on top of their dementia, and then they would meet that criteria. So you can see how we formally need to meet these specific criteria in order for somebody to be eligible for hospice with dementia. That being said, the choice to enter hospice is really an individual choice, typically based on substituted judgment for the patient, because they can't often at this stage tell us what they would want. So we hope these conversations have happened earlier, And if they haven't, it's based on what you think this person would want, on their goals, on their values, and what's most important to them. So I often say to families and friends, uh, let's talk about your loved ones' quality of life. Is this a quality of life that they would say, yes, this is acceptable to me, and I want to continue doing this? If not, we might say, okay, then a hospice level of care might be appropriate, or palliative care, to focus more on comfort rather than prolonging somebody's life or death. So I also like to talk about, why would I want hospice and palliative care? So there are a number of benefits. First, palliative care and hospice care have been shown to improve symptoms and reduce suffering. This is often things like reducing pain, shortness of breath, and anxiety that can come along with a diagnosis. For folks with dementia, we can often help with behavioral symptoms, agitation, um, and there can also be pain, especially at the end of life when somebody's more bedbound. It also reduces unneeded visits and procedures. People will often say to us that when they're getting toward the end of an illness, that they don't want to spend their time in the hospital, going back and forth to the emergency room or to the hospital. And we find that people who have a hospice or a palliative care type um, care go to the emergency room less, have shorter hospital stays, fewer unnecessary office visits, and fewer needle sticks and procedures. And then finally, it improves caregiver satisfaction and reduces their stress. As I noted, this is not just for the patient, but also for their family supports. Um, so this type of care can provide really excellent resources to caregivers. People say that they're more prepared for the end of life, which can also improve the bereavement process, reduce stress, and reduce the physical burden of caregiving. A question I often get is, does specifically hospice care hasten death? I will say without a shadow of a doubt, hospice is not intended to hasten somebody's dying. We don't provide medications to shorten somebody's life. There is an option called physician assisted or provider assisted dying. Excuse me. We don't have that option in Pennsylvania or New Jersey or any of the surrounding states. That is different. Hospice is about supporting somebody's life until the end, until they die. We may provide pain medications. Often people think about a medication called morphine and worry that by us giving morphine, we're hastening somebody's life, which is really is not the case. We're providing morphine or pain relief to, and we titrate it to somebody's comfort, but not to hasten their death. So I think that's a really essential thing to understand, because I know that it's a real fear that people have about hospice care. What can I do now? Let's say you're very far away from having to think about the end of somebody's life. There are things that even I've started doing it in my life to prepare for thinking about illness and what I would want. The first thing is something we call advanced care planning. And there are two parts to that. The first one is designating somebody who would make decisions for you if you couldn't, or your loved one. And the second part is what you'd want those wishes to be if you were at the end of life. Typically people talk about, do I want, if my heart were to stop beating, if I were to stop breathing, would I want CPR and intubation, which is a tube in somebody's airway to help them breathe? Oftentimes, especially in dementia care, there is a point at which we say, if this person's heart and lungs were to stop working, we might not want to do CPR or intubation. And there's forms that you can complete that would help healthcare providers know that that's what your loved one would or would not want. I have, for example, designated a healthcare proxy, somebody who would make decisions for me if for some reason, let's say I was in a car accident, or suddenly became very ill, and wasn't able to tell somebody, hey, this is what I would like for my healthcare. They know they should ask this person. That's especially important for people with dementia to do early, because at some point they may lose the ability to designate that person. So we really encourage people to do that early and revisit it if necessary. The second piece is, okay, so designating a person is great, but there needs to be a conversation between the person who's designated and the person who is ill, or the person who's designating a surrogate or healthcare proxy. We find that those conversations are the most impactful when the healthcare proxy is in the situation of needing to make decisions. I like to focus those conversations on what gives a person meaning in their life. So, like, for example, I just recently had this conversation with my in-laws, and we sat down and we said, what is important to you in life? What gives you quality? What gives you meaning? And I loved the way my father-in-law put this. He said, if I were able to make small steps toward a goal in my health, that would give me meaning. I would still want to do that. And that was really helpful for me as a person who might, have to make decisions for him. He's not ill. He's a little bit older, but I don't expect we're going to be facing this decision anytime soon. But that conversation really helped me to understand how he might make healthcare decisions if he were to get suddenly very ill. And there are so many online resources that can help you and your family members guide your way through these discussions. And I do have a list of resources that I can share with Allison to send out to the group. So, in summary, palliative care is an umbrella of care, a large philosophy of care that's focused on reducing suffering, improving quality of life for anyone at any age and any stage of illness. Hospice care is specialized care that's just for people at the end of life, typically the last 6 months or less. It's always provided by a multidisciplinary team. It's provided anywhere you receive care, so in the hospital, at home, in a nursing home. It's focused on symptom relief and quality of life. When to start and access this type of care is very individualized based on somebody's goals and values and their health status. It does not hasten death, and you can start to prepare now for making sure that you're able to access this type of care at any point in along your life and health journey. And this is especially important for folks with dementia to start having conversations about early, and preparing them for this journey that they're on. But at the same time, it's really never too late to start having conversations like this as well. So if you're at a point where you haven't had this conversation, don't worry. It's still something that can be supported, and we can help understand. You've also known, often if you're making choices for somebody, healthcare choices for somebody, you've known them for a long time, and that palliative care providers are really well trained in helping somebody talk through what they've known about an individual to understand what their goals and values are for healthcare. With that, I just want to say a huge thank you for giving me the opportunity to talk to you. I know it's not always easy to talk about hospice and palliative care because there's, folks don't love to talk about death and dying, but I think it's really valuable to have as much information as possible, and be prepared to make these decisions. We often say in palliative care, we hope we don't have to use this information, or we hope we won't get there, but we worry that we might. And we know is one of the factors of human life is that we will all come to the end of our lives at some point. And so I hope this gave you some tools and some confidence to feel like you can make good choices about your and your loved one's health.